Hi, everyone. It's such a pleasure to be here with you today, and so very grateful that you're taking time out in the middle of your day to listen to us. Breast cancer is a journey that no woman or man chooses, yet it is one that many find themselves navigating. At our clinic, we often meet women who, despite focusing on their well being and health, are suddenly confronted with the fear and uncertainty of a breast cancer diagnosis, whether it's their own, a loved one's, or a close friend. This webinar, Overwhelmed but Strong, Empowering Your Choices After a Breast Cancer Diagnosis, is designed to acknowledge those feelings of fear while also providing a beacon of hope and strength. Together with two exceptional experts and truly very special individuals, a breast Dr. Anthony Tang and a breast cancer physiotherapist, Ms. Sheni John, we aim to arm you with the knowledge, resources, and support to help you take control of this journey. In recognition of Breast Cancer Awareness Month, we are here to help you turn fear into empowerment and to remind you that you can take control of your journey and emerge stronger than ever before. I'd first like to introduce Dr. Anthony Tang. He's a specialist breast cancer surgeon with clinical interests in breast conservation surgery, breast reconstruction, and oncoplasty, sentinel node biopsy. Dr. Tang was awarded the prestigious Commonwealth Scholarship for Medicine for his undergraduate education in Melbourne, and he went on to complete postgraduate surgical training and conferred a joint specialist fellowship with the Singapore and United Kingdom boards. Dr. Tang also has two additional postgraduate master's degrees in medicine and public health. He now helms the breast clinic at Paragon, but has over 20 years of experience as a minimally invasive and breast cancer surgeon at National University Hospital, after which he continued his practice at Raffles Medical Group. Welcome, Dr. Tang, and we look forward to you shedding light on the path from breast cancer screening to diagnosis, treatment, and finally towards recovery. I'd now like to introduce Ms. Sheni John. Sheni's greatest passion is to help people alleviate pain. I always say that she has an incredible touch and kindness. She's a specialist in breast cancer physiotherapy and recovery. She completed her certification in manual lymphatic drainage from the Dr. Vodder School in Washington, USA, and is one of the very few certified manual lymphatic drainage physiotherapists in Singapore. Ms. Sheni will discuss the best ways to prepare before surgery, how best to manage complications, particularly lymphedema and cording. Many of you know me. I am Sylvia Ramirez, the Medical and Scientific Director at Cutis Medical Laser Clinic. And many patients ask me, why are you doing this? And the reason is our focus is on patient education. We want to empower women to regain their confidence and sense of self, whether through aesthetic treatments, but more importantly, through evidence-based knowledge. Although I am moderating this discussion, please, I encourage all of you who are listening to ask questions. No question is too simple, and we will do our best to cover all of them. I'm going to start with screening mammograms. And I'm going to turn first to Dr. Tang. Dr. Tang, when should a patient get a mammogram and how often should one be performed?
Thank you so much for the kind invitation to join this webinar. And I really hope, just with everyone else as well, that this would be very informative to everyone out there and will definitely help in breast cancer awareness. And so back to your question about mammograms. So for most, unless you have a very strong family history in which your screening program would be customized to you, for most people, screening would start at the age of 40. Now, screening mammogram means that you do not have any symptoms, you don't feel a lump, there's no discharge from the nipple, there's no change in color in either of the breasts. Everything is as per normal. Yeah, but because the incidence of breast cancer is quite high, all around the world, in Singapore as well, almost 1 in 10 women get breast cancer. Thus, all women from the age of 40 should go for a mammogram once a year. Now, from the age of 50, you can choose to do it once every 2 years, but I would still recommend continuing once a year if cost and the slight inconvenience is not too much.
Great, that's wonderful. And I've heard that sometimes, in addition to a mammogram, an ultrasound is also performed. In what cases would this be needed?
Right. So the minimum for a breast check is doing a mammogram. Mammograms and ultrasounds actually show different kinds of information. It often overlaps, but it's additive to each other. Yeah, it's not the same type of information. So mammograms, the strongest strength of a mammogram is being able to pick up microcalcifications, which in some forms, shapes, and design is an indication of a very, very early type of breast cancer. Ultrasounds do not see this. Only mammograms see calcifications well. However, ultrasounds can pick up very small lumps from 3 to 4 millimeters upwards, and these are sometimes missed by mammograms. Hence, it is usually a good idea to do both at the same time, a mammogram and ultrasound. Also, if a mammogram shows a potential lump somewhere, then an ultrasound would definitely be called for. Yeah. And so once again, if cost is not a huge issue, then once a year, you should do a mammogram and ultrasound.
Okay, that's very clear. But that since you mentioned lump and you mentioned screening, what about if I feel a lump or a change in the breast? Should I
Okay.
worry? And what types of lumps should be checked?
Okay. So now that, let's say a lump is felt, so this is not called screening anymore. There is now an actual symptom. You actually feel a lump. Yeah. So basically, all lumps, no matter what age, should be checked. Now, the vast majority of these are going to be normal type breast lumps. And the medical term for it is benign, meaning not cancerous. So just to reassure everyone, the vast majority of breast lumps are not cancerous. However, as a member of the public and not medically trained, it's quite difficult for one to differentiate, a cancerous lump from a non-cancerous lump. Hence, it's always a good idea to get all lumps checked, no matter what the age.
Great.
Was the next question going to be, so what is going to be done for the lump?
Yeah, that's right. Exactly. That's exactly right. So, um, if you see this lump and I visit you and you then go for a mammogram and ultrasound, what would be the next steps? Will I need what's called a biopsy at that stage?
That's very good. So, very good question. So, depending on the patient's age and the clinical suspicion of what is going on, then either a mammogram and ultrasound, or sometimes just an ultrasound is done
Okay.
to check for palpable lumps that can be felt. Yeah. Now, these scans would give the doctor a better idea as to whether this lump is something dangerous or not dangerous, or how many lumps are there. Sometimes when you can feel one lump, the scan can reveal other small lumps, which you cannot feel, but which may have a slightly dangerous shape. And hence, any lump that can be felt or lumps that have a, uh, uh, a, a shape that could be something dangerous, all these lumps should be biopsied. Okay, so what is a biopsy? Because we are using the term now, right? Biopsy. So a biopsy is basically a way in which doctors take a tissue sample from the lump to confirm its exact entity, exactly what this thing is, yeah? And therefore being able to confirm for you whether this lump is something dangerous or not dangerous.
Right. And are there different types of biopsies? And when would you recommend one versus the other?
Right, okay. So there are a few types of biopsies, yeah? And so I'll go through a few of the basic ones, yeah? Kind of thing. And depending on the lump, the size, the degree of suspicion, your doctor may suggest one of these various sorts of biopsies. Now, in the past, there was only one type of biopsy, which is a surgical biopsy, or also known as an open biopsy.
Mm.
So that biopsy involves an operation where you need to make a big cut to take out whatever size lump, okay, to send it off to the lab to get it checked. That was the only way to get tissue sample to confirm the exact nature of the lump. However, nowadays, with the advent of modern devices and stuff, we have a plethora of small needle-like devices that can do the same job. It can take samples from the lump, or some cases can actually remove the whole lump to actually examine it under a microscope to confirm the nature of it. Yeah. So the smallest needle is what's known as a fine needle biopsy. So these are good for cystic structures. It can suck out fluid to send for testing. And nowadays, though, it's not so much used for solid lumps because the amount of tissue you can get from these very small needles is very little. And hence, sometimes it's not conclusive. So for most lumps, your doctor would recommend what's known as a core biopsy. Now, a core biopsy is a needle that can take out a sample from the lump, but the lump is still in the breast, it's not removed. We just take a sample, and that is enough to confirm what the lump is. Okay, that's level 1 type biopsy. The next level biopsy is what's known as a vacuum-assisted biopsy. It's another sort of needle, slightly bigger, but this needle is special because it can actually produce a vacuum force inside the breast, hence sucking the lump into its particular aperture. There's an opening in the particular needle, which can then remove the lump bit by bit, such that the entire lump is removed, and then all the tissue is then sent to the lab for what's known as histological analysis. In other words, we check it under the microscope to see the cellular structure and to determine whether this is something dangerous or not. Yeah. So the core biopsy removes the sample, the lump is still inside the breast. The vacuum-assisted biopsy removes the whole lump and then sends it off to the lab to get it checked. Yeah. Now, all these are different ways of obtaining tissue sample to check what the lump is. Should the lump be something dangerous, you still need definitive treatment, usually in the form of some sort of surgery. Yeah, so this device, even though it removes the whole lump, if it's something dangerous, you still need further surgery.
Right, that's excellent. And in terms of now, I'm going to bring in now Miss Shani. In terms of recovery or even preparing for a biopsy, would you have any recommendations to patients who are going for a biopsy? Are there exercises, things that they can do, massages in order to recover faster and to make the biopsy process more comfortable?
Hi, Dr. Sylvia. Thank you for your introduction. So, as Dr. Anthony has been mentioning, right? So it's one of the tool to actually find out what is happening. Usually, at this stage, patients are not coming for any physio interventions because it's still like under screening processes. But usually I come across such patients who are my current patients undergoing some other treatment. And if they tell me they are undergoing biopsy, they are worried, anxious, is there anything? So especially when you look into patients who already have some shoulder or other breast related issues who are seeing me, I usually check on their range of motion and post biopsy, usually they don't come to me that immediately, but I will teach them some gentle lymphatic drainage techniques to overcome the soreness and the discomfort what they have. But I won't be going into too much of detail into the interventions at this time because I want to rule out what is happening from the doctor's side first. Yeah.
That's great. Yeah, that's essential to just highlight the priority at this stage. And I want to then turn back to Dr. Tang.
Mhm.
And let's say, first of all, how soon after the biopsy would I get a result, for example? And let's say it is positive. On average, I know there are many, everyone has a different journey with breast cancer, but what would be the high level next steps? Let's say the biopsy result turns out to be positive for cancer.
Okay. With regards to the first question, most biopsy results would come out in anywhere between 2 to 5 days, and depending on whether additional stains, in other words, now we are trying to define the subtype of what is found, okay, whether certain stains need to be done. So certain stains take a bit longer. Yeah, so anywhere between 2 to 5 days, we should get the full result. Now, let's say this lump turns out to be cancer. Depending once again on the age of the patient and also the size of the lump, some additional scans such as an MRI is sometimes necessary to further plan the next step, especially if the next step is going to be surgery. Basically because all signs of cancer would need to be removed. And sometimes there might be one main cancer, but this main cancer can have a few daughter spots around, what's known as multifocal or multicentric breast cancer. And because these spots sometimes are small, they can be missed by the conventional scans of the mammogram and ultrasound. And sometimes, especially particular subtypes of breast cancer, you would need to do an MRI to make sure that nothing is missed. So after a biopsy, if it is cancerous, first thing, you might need additional scans to be done for further planning. Yeah, besides the MRI, sometimes a PET scan needs to be done, a PET CT. Now, if you were in a restructured hospital, usually a bone scan and CT scan is done. So 2 scans are done. In private practice, usually we just do 1 scan, which is a PET CT, which does the same function. And that aims to check to see whether the cancer is just in the breast or whether the cancer has got any signs of moving somewhere else to another organ, such as the bone, the liver, or the lung. So this information is all very important because then it will determine the next step of treatment. Now, nowadays, breast cancer treatment is multimodal. In other words, we need a few types of approaches to be able to take care of the cancer as good as possible. Yeah, and these modalities can be broken up into surgery. I'm sure we'll talk a lot more about it. Number 2, potential chemotherapy. Number 3, potential radiotherapy. And number 4, okay, so a lot of people think of chemotherapy as any medication that's put into a drip and goes into your arm, okay? They term it all chemotherapy, but it is, there are different types nowadays. So they're very targeted type chemotherapy, so to speak. So we call them targeted therapies, okay? So it's another form of a drip of medication, yeah? And then the last type of potential treatment you may need is actually in the form of tablets. And these are usually hormone blocking tablets that you need to take if your particular cancer is responsive to hormones, which your doctor will check for you. Okay, so once again, the potential treatment arms that you may need to undergo: surgery, chemotherapy, targeted therapy, radiotherapy, and sometimes tablets as well.
That's really a lot of information just in that one answer. My next question is, are all breast cancers the same? And which ones do you think are generally the most common? And these ones that are very common, what does a staging mean when you stage a cancer?
Right. Okay. So we'll talk about different types of breast cancer, what's common, and also, a little bit about staging and what staging means to the patient, especially. Yeah. So by and large, still the most common breast cancer is okay. So for all cancers, basically, we usually check for three receptors. In other words, whether this particular cancer is responsive to the estrogen, so it's an estrogen receptor, progesterone, another hormone, so it's a progesterone receptor, as well as what's known as a HER2 receptor. Okay. To simplify things, the combination of these three tells the doctor how aggressive the tumor is. So each of these factors, the ER, PR, and HER2, can be positive or negative. Yeah, so you can have positive, negative, negative, positive, positive, negative, etc. So all sorts of combinations. Yeah. Now, in the younger by and large, still a lot of people have ER and PR positive cancers, HER2 negative. So this type of cancer is responsive to hormones and is the most common. And amongst all the cancers, it is the least aggressive. And this type of cancer still happens very often to ladies above the age of 60, above the age of 55, something like that. Yeah. Kind of thing. So this is still the most common cancer around. However, we notice a trend of the younger patients now getting breast cancer as well. Unfortunately, for the younger patients, very often they have a slightly more aggressive form of cancer. In other words, the HER2 now is positive, or sometimes all three are negative, what's known as a triple negative breast cancer. These kinds of cancers are more aggressive, usually more found in the younger age group. When I say younger age group, it can be anyone from below the age of 45. Yeah, so 35 to 45, sometimes even younger. Anyone younger than the age of 45. Yeah, so these are the broad classes of cancer that we have. Now, no matter what your type of cancer is, okay, how aggressive it is, we often stage it as well. So the older forms of staging does not take into account this ER, PR, and HER2, but the latest forms of staging takes this into account as well. Basically, staging a cancer, which is divided into stage 1, 2, 3, 4, depends on the size of cancer, how aggressive the cancer is, and whether lymph nodes are involved. Yeah. And so the earlier the stage is, so let's say stage 1 cancer, basically the cure rate is higher and the rate of the cancer coming back is the lowest amongst all the cancers. So basically, if the cancer is treated early, which is the main thing, take-home message for everyone all the time, if your cancer is treated early, your cure rate is the highest and is the most likely that the breast can be conserved. We do not need to remove too much tissue. Yeah, so breast can be saved and lives can be saved too if the cancer is detected early. Yeah, stage 2, stage 3, stage 4 basically then means that the rate of recurrence, the likelihood of the cancer coming back becomes higher and higher. Okay, and also survival, unfortunately, then goes down. Yeah, so survival from stage 1, which is nowadays in excess of 95%, goes down to about 60% in 5 years for someone in stage 4. Yeah, so it drops down as well. So it tells the doctor what is the potential, what's known as the prognosis, what's the outcome for this patient should everything be done properly. Yeah, so the later you present, you go to see a doctor, the more advanced the cancer is, then unfortunately, we know that despite best efforts and all that, yeah, the outcome is still obviously not as good as compared to if you go early when it's like stage 1. Yeah, so
Of
that's
course.
what staging is for.
And the importance then of screening. And
Absolutely.
yeah, and just if you could also share as briefly as you can, just because we have a lot of questions, a lot of topics. I think a lot of individuals may not be aware that men can also get breast cancer. Are there different implications when a male person gets cancer, or is it going to be a similar approach generally?
Right. That's a very good question, actually. So at one stage, some time ago, when I used to be in public practice, I think I had one of the biggest cases of male breast cancers by a single surgeon because I just happened to see a lot of males having breast cancer. Um, so basically, out of 100 people who have breast cancer, one is male. So it's not very common. Yeah, so for most males, you don't need to go for a screening mammogram. You don't need to go for a scan every year.
Right.
Yeah, also because the amount of all males have a little bit of breast tissue behind the nipple, but the amount is very, very small. Hence, the likelihood of a male person getting breast cancer is very low. Yeah, out of 100 people who have breast cancer, only one is male. Yeah, and most guys, because the chest is kind of flat, so it's quite easy to feel something, even though the lump is quite small. Yeah, so most guys actually come to see the doctor because they actually feel a lump. Okay, the treatment for breast cancer for males right now is very much like how it's treated for women. Okay, however, because they are males, the likelihood of them having a genetic issue is higher than for a lady, any lady who gets breast cancer. Hence, for all males who get breast cancer, and then it is highly recommended that they go for what's known as genetic testing as well, to see if they carry any breast cancer genes that can potentially be passed down. Yeah, so then they would be more informed. Treatment can be customized more for them. And of course, potential preventative measures and checks can be done for their offspring and kids as well.
Right. And the risk, let's say it's a genetic factor, would the risk be, let's say it's positive, would the risk be higher even if the child were female?
Yes. So if someone has, so the most common breast cancer genes are what's known as the BRCA or BRCA genes, 1 and 2. Yeah, and one of the most famous personalities to have this gene is Angelina Jolie. And because of her, actually, a lot of people, woke up and knew a lot more about this gene. Yeah, although it's been around for a long time and doctors know about it. Yeah, but the public became more aware. So if you have this gene, we know that the risk of breast cancer, okay, for females is around about 85%. So it's extremely high for
Yeah.
your lifetime. Yeah. And hence, doctors would then, so if you are gene positive, then doctors will need to talk to you about something like what Angelina Jolie did, right? So she knows that she's of very high risk of breast cancer. So before she had any cancer, she had all the tissues in the breast, both sides removed, and had reconstruction. Yeah. Then when she finished having her family, the gene also tells us that you are of high risk of ovarian cancer, around about 50%.
Wow.
And so when she finished with her family, she had the ovaries removed as well.
Right.
Yeah, so doctors can talk to you about this, whether you would like to undergo this, or the alternative, of course, is to have more frequent checks. Yeah, so when I say you have 85% of getting breast cancer, it also means that 15% don't get any breast cancer at all, right? So it depends on how you look at it. And so one might then decide, okay, I don't want to have surgery, but perhaps I'll just go for more frequent checks to make sure that everything is okay. So that's an okay approach as well.
And before I ask my next question, I'd like to encourage the participants also, if you want to put a question for Dr. Tang or Ms. Shaney, please write it in the chat. In the meantime, I'm going to now go into surgical approaches to cancer. I mentioned to you in one of our conversations that there's this incredible book talking about the history of cancer. This is a really great book. And what struck me about breast cancer is even as recently as maybe a decade ago, the types of treatment approaches were really extremely aggressive and sometimes deforming. Maybe this is longer than a decade ago. But nowadays, with advances in understanding more the tissues and the techniques, that it is so much less aggressive in the sense that you're still removing the tumor, but you may not need to remove as much of the normal tissue as it used to be in the past. And so it leads me to my next question, which is, what are the types of surgery that can be done for breast cancer? Let's say it's a biopsy. You believe that the best treatment approach at this stage is surgery. So, what are the types of surgery? And while you're on this topic, what are lymph nodes and why are they important to consider in breast cancer surgery?
Thanks, Sylvia. Okay, so obviously as a surgeon, this is a topic of close to my heart kind of thing, because this is something that I do day in, day out, as a profession as well. Yeah, helping ladies to overcome cancer, especially in doing the surgical part of things to help them get well. Okay, so maybe I'll just tell everyone a little bit of history as well. So maybe about 50, 60 years ago, the only surgery that was available for breast cancer was what's known as a radical Hallstatt mastectomy. That involves not just removing all the breast tissue, it also involves removing the muscles on the chest wall, what's known as the pectoralis or the pecs, major and minor, and all the lymph nodes in that particular area as well. So doing this kind of very, very radical surgery, fortunately, it did cure a lot of the ladies, and the cancer did not return, but it was extremely debilitating. They had very large, bulky arms because of lymphedema, which Shani will share a bit more later about. And I'm sure Sylvia will talk a little bit more about it later as well. And not only that, but because all the muscular structures were greatly removed, then the strength and the use of the arm became very, very much reduced. They had a very weak arm. It was very obvious that something had been done. Yeah. And so because of all this, yeah, so it was a very, very radical type surgery. Now, through the many, many years now, we have learned and come to know that we can approach breast cancer in many, many ways now, and doing less and less surgery, but maintaining and having the same good curative and survival effect. In other words, the outcomes are still as good as what it was, when it was extremely radical, but doing a lot less, maybe with the help of other treatment modalities, but the surgical part becoming smaller and smaller. Now, this, of course, is helped greatly, aided greatly, if the tumor is small as well. Hence, once again, the very important role of finding, if you're unfortunate enough to get cancer, if it is found at a very, very early stage, when it's very small, then the whole range of potential surgical options are open to you. However, if the patient still goes to see the doctor at a very late stage, then sometimes there are not many surgical options left. Yeah. Now, the main aim of surgery is basically to remove all local traces of cancer. In other words, all traces of cancer in the breast, and cancer in the breast tends to move towards the lymph nodes, which is found in the armpit area. Okay. And so all traces of cancer, whether it's in the breast or in the lymph nodes, would have to be removed. Okay, that's the aim of surgery. Yeah, we'll talk about what chemo does later on, but we just concentrate on surgery first. So in modern surgery nowadays, basically there are two main forms. One is known as a lumpectomy. In other words, the vast majority of the breast is conserved, is kept. We just remove select portions of the breast. Yeah. So wherever the tumor is, if they're all small, we can then even cherry pick. We can pick out small amounts of tumor from a few areas. However, once again, if the tumor is very large, we may not have this option to do a lumpectomy because the amount of tissue removed is going to be very, very large as well. So if the tumor is small, we can do a lumpectomy. That always goes in hand with radiotherapy, which we'll talk a bit more later. Okay, but basically, most of the breast is conserved. Yeah, there is another way also to reduce the size of the tumor. Now, let's say the patient came with already a rather large size tumor, 4 or 5 centimeters. We can nowadays give chemotherapy with very, very good effect. 70% of these tumors will shrink by more than 50% in size. So a 4 centimeter tumor will become a small 2 centimeter tumor. So when it's 4 centimeters, perhaps doing a lumpectomy was not possible because too much tissue needs to be removed. But after giving chemotherapy, so we don't do surgery first, we give chemotherapy first, and the tumor shrinks down to 2 centimeters. Now it is possible to do a lumpectomy. Yeah. Okay. So lumpectomy is one option, goes hand in hand with radiotherapy. Now, the other option, some tumors don't shrink, or sometimes the patient comes quite late, the tumor is already quite large, and then we may not have options here. Or sometimes there are too many tumor spots. It's called multifocal, too many spots of tumor all around, and hence we need to remove all the breast tissue. But nowadays, we know it's quite safe. In most cases, you've got to discuss with your doctor about this, but in most cases, it's quite safe to keep the nipple, areola, and the original skin covering. So what the surgeon then does is remove the cancer and all the breast tissue inside, but keeps the outside covering, the skin, the nipple areola, the original skin and nipple areola intact. Now that the inside is removed, then obviously there's going to be a cavity inside. So the cavity can then be filled with either an implant or with the patient's own tissue. Sometimes it can be a combination as well. So we can sometimes take a bit of tissue from the tummy or from the back kind of thing, and depending on what needs to be done, we can also supplement it with an implant to make it equal on the other side. Okay. Sometimes ladies choose to augment the other side at the same time. So basically, now that we're reconstructing one side, they may choose to perhaps go up to a bigger size, and hence augmentation, in other words, putting in an implant on the other side at the same time, at the same surgery is possible as well. Okay, so these are all combinations of what can be done. Now, if the lady is very voluptuous, so she has got a big breast size, then sometimes, even though the tumor is large, okay, we can still conserve the rest of the breast. So we remove the tumor with a good rim of tissue, but because there's a lot of breast tissue, it's a bit like a breast reduction on one side. Yeah. And on the other side, we can do a control at the other side breast reduction as well. Yeah. So now instead of looking at it as a cancer surgery, it's more like having a breast reduction on both sides to make it equal. So these are all combinations of what can be done for surgery, but remembering the main aim being all traces of the cancer in the breast as well as the lymph nodes need to be removed. Now, why do we need to remove all the cancer in the lymph nodes? Well, basically because we want to remove all traces of cancer, because if we leave any behind, this residual amount of cancer can potentially spread to other areas. Hence, it is dangerous for the patient. Yeah. So during surgery, very often, so in the past for the armpit area as well, there was only one form of surgery, which is basically removing all the lymph nodes in the axilla, in the armpit area. And that often results in quite a lot of arm swelling called lymphedema. Okay, but nowadays we can reduce that rate to nearly zero by doing what's known as a sentinel lymph node biopsy. So instead of actually removing all the lymph nodes immediately, we take out selected nodes, check them during surgery whether they are affected by tumor. And if they are not, which is the case majority of the time, we do not need to touch the rest of the lymph nodes, hence reducing the what's known as a morbidity, in other words, the complication of having that arm swelling condition known as lymphedema. Yeah, so there are a lot of advances of surgery which removes the tumor, removes smaller amounts, but still having the same good survival and overall outcome. Yeah, so that's all the advances that's happened in surgery.
Such a positive message, not to be scared, and there are things we can do if we do it early. It leads me now to ask Shani. Dr. Tang mentioned lymphedema. Could you describe this condition a little bit more for us? Because from what I know, it can indeed happen when all the lymph nodes are removed, but even if it's just a biopsy, it may also occur. So perhaps you can give us an understanding. What is lymphedema? Why is it something that we should think about? And what are the ways to prevent this?
Yeah, so when you talk about lymphedema, as Dr. Tang was explaining to us about the sentinel lymph node biopsy versus an axillary clearance, the risk of getting lymphedema is much lesser with the very low risk who has undergoing with sentinel lymph node biopsy. But a person going for an axillary clearance who are at higher risk of getting lymphedema. Okay, so we talk about lymphedema. It's actually an accumulation of protein-rich fluid that is actually usually drained through the body's lymphatic system. So when the lymph nodes are removed, there's a blockage which is happening at your axillary area, which is draining towards your hand. So there are certain factors you need to take note to prevent from getting lymphedema. So we will go into a bit more detail of that. So research has shown us that when you exercise and when you take care of your arm, this can be totally prevented. But what I see in my patient is during the acute stage, they are very careful. And after certain time, they are like, they think, they assume it's not going to happen. And then they go and experiment on a lot of things. And they come back to me even after 10, 12 years with lymphedema. That's what I do come across. Yeah. Um,
Yeah, and what I know and what I've read with lymphedema is can really be debilitating. Like
this.
you can there are those where it's painful or it's difficult to move the arm. So if you're someone who does a lot of fine work, you could be limited if there is this lymphedema.
So it is very common if you see like older patients coming to me, there's no education or like an awareness given to those patients. So some of them are coming to me like to say, so when I talk about like how did you get lymphedema, they said it just happened after my chemo, my radiation. But when you ask them more into detail, you actually find out they would have done like a very hard massage, which they are not supposed to do. They have traveled long flights or even short flights without any compression garments on their hand, which could have lead. And I even had patients who had like a small mosquito bite, which they ignored has caused inflammation and do come back to me with lymphedema. And some of them, they think that is normal, it can't be treated. So I do have very young patients in their mid 30s with a very bad lymphedema and they're living with it, but they know when they want to buy clothes, it's not appropriate for them to buy a ready-made clothes because one of the sleeve can't put in. So they have to make a lot of adjustments. But with the new awareness, people are more careful about what they can be done to prevent from getting lymphedema. Yeah.
The other thing, Shani, is when I walk in a mall, I look at the spa and it says manual lymphatic drainage, right? So it seems it's a term that is used a lot, but whether or not it is done appropriately is really unclear. Because I remember in one of our early discussions, what struck me the most about lymphatic drainage is it actually is a very gentle touch. It's really, really light because the lymphatics are very superficial. And so could you comment a little bit on that? Do you feel that this is actually the case, that the term manual lymphatic drainage may be overused even if a person really is not properly trained for this, and how important it is to go to an individual who truly understands MLD?
Yeah, so when you even look in Singapore context, a lot of spa, massage parlors, facial places claims they are doing lymphatic drainage. They won't use the word as manual, but they say lymphatic drainage. So I do come across with a lot of people who have done like mainly overseas patients. If I say that, they said I have tried to get it done at a at an outlet, and I ask them usually how was the massage. So say they tell me some of them may use hot stones, they use very hard pressure, it's very painful. So a lot of them, when they come to me after breast surgery, they are very scared. So sometimes they may even call to check to say, I'm still having drain, I'm still having a lot of pain, I know this massage is going to be painful, so is it appropriate for me to come now? So the first thing what I do before even touch a patient is to talk about the lymphatic system. And I do tell them lymphatic system and your lymph nodes are very superficial and it is just under the skin. So we call this massage as a skin stretching technique, and it is done very superficially. We won't be using any cream, oil, or any substances. This skin to skin stretch massage. So that actually helps to promote your lymphatic fluids to drain. So when you talk about a lymphatic massage, and if a patient is coming to me with a swollen arm or a swollen wrist or a forearm, we don't immediately start treating that area. We usually start at the unaffected parts. So imagine if it's a swollen arm, we usually start at the neck region where they have the cervical lymph nodes. And then we go part below and then eventually draining this swollen area. So we won't focus just at the swollen area. We just make sure the other lymphatic vessels are open up first so that you could drain the fluid up towards the other system. So the circulations get better.
Right.
Yes.
And
I've got a couple of questions for
go
Shane.
for it.
Okay. Firstly, do you have any advice for patients who have undergone either a sentinel lymph node biopsy or axillary clearance to prevent
Yes.
lymphedema? That's the
Yes.
first
Yeah.
question.
So first
And then
of
the
all,
second question is, for patients who have not undergone any surgery, would you recommend that they go for these types of lymphatic drainage in spas and all that? Does it actually help them in any way?
Okay, so coming back to your first question, patients who are undergoing with sentinel lymph node biopsy and axillary clearance, I do talk about the risk, low and high risk for sentinel lymph node and axillary clearance. So when they are coming, if imagine if they have not gone for surgery, when they come to see me, I do upper limb measurements on both sides. So this is like a baseline measurement for me to compare post-surgically. But most of the times what we come across, majority are seeing us post-operatively. So on the first session, I do measure both arms to see any difference. And I do talk about the prevention. So when you talk about the preventive measures, there are a few key points they need to be aware of. First and foremost, I will tell them not to do any hard massages on their breast as well as the arm which they have removed the lymph nodes. And some of them may ask, is it like a temporary, like a 6 months or 1 year? I would tell them it's a lifelong, because lymphedema can happen anytime. And if you notice at the research, it's 1 in 5% do get lymphedema. So first of all is no hard massages at the breast and as well as the arm. Secondly, apart from a certified manual lymphatic therapist, in Singapore, we do have only medical people like physios, occupational therapists, whereas in overseas, even masseurs, like a massage therapist, are trained in that. But as long as they are certified persons, they can do that. But I will tell them it's a very gentle and a soft technique. Yeah. Secondly, to avoid that hand for any procedures for lifelong, like injections blood taking, vaccination, even some of my patients go and try acupuncture. So I will tell them anything causing pressure onto the skin, they have a higher risk of getting lymphedema.
Mm.
So have to be totally avoided. But I do have some patients done right side sentinel lymph node, left side axillary clearance. So they do ask me whether they should avoid both sides. I would say better to avoid if you have an option. If not, you can take the hand which they have done a sentinel lymph node
Mm.
biopsy, or use the legs if they need.
Mm.
And then usually I advise them to get the compression garments for flight traveling, for even for short or long hours flight. It's because of the atmospheric pressure
Mm.
that helps to control the lymphedema quite a lot.
Mm.
Even if imagine if they have seen me on the first session, I will tell them if you see any signs of lymphedema from here onwards, the first line of management is to wear the arm sleeves, the compression garments, and you should see some changes. And if you don't see any changes within a week, you should come back to me. Don't delay, even say 1 month or 2 months. Sometimes swelling comes and goes, but you should get it treated, because earlier you come, it can be managed better. And the most important thing, I talk to them about the skin care at the arm to prevent from any cutting of the skin, any rashes, any dryness, so that you don't get an open skin in your
Mm.
hand, including insect bites. So I will tell them to moisturize and keep their skin supple. Yeah. And compression garments are usually very tight. It's meant to be tight, but I do tell them, apart from the compression garments, do not wear anything too tight onto their hands, like tight rings, watches, or even tight gym clothing. I will tell them to avoid. And the exercises, what I'm teaching post-operatively, I will tell them this is considered like lifelong exercise. In between, you actually have to do that to maintain it. Yeah.
I want to just say, I mean, incredible information from both of you. I just got a prompt that our time is really up, but
Oh.
I have I think we need a part two. Now there is an anonymous question, maybe to Shani.
Yes.
The advices you gave are those applicable even if it's just a sentinel lymph node biopsy?
I do reinforce them, because I do have patients coming back after some sentinel lymph node biopsy with mild swelling. So I do tell them it is important for them to monitor, as prevention is always better.
Yeah.
Mm.
Yeah, so accidentally add on to it, accidentally, because a lot of ladies are like gardening, they are doing housework. Sometime accidentally they may have a cut, and sometimes they get panic. So I tell them to get some antiseptic cream and make sure it's getting treated. But if you see more signs of inflammation, go back to your doctor and get with your antibiotics to get it treated as well, because we may not want to end up with some cellulitis or bad infection which can trigger the lymphedema more.
I want to just say, first of all, Shani and Dr. Tang, such incredible information. You can see the interest. Nobody has signed out. And I'm very sure if we could extend by at least another hour, this will be a fully loaded hour. I encourage all of the participants to please send us questions, or you, of course, can communicate directly with Dr. Tang and Shani. Dr. Tang is, we have your information. It's on the announcement, and the same with Shani. Just two incredible individuals. But I want to express my deepest gratitude to both of you and to every one of you who joined us today. And as Dr. Tang and Shani mentioned, facing a diagnosis of breast cancer is terrifying, but ignoring it is far more dangerous. Think about breast cancer screening and early detection as not medical tasks. These are acts that empower you, that allow you to take control of your health and face the future with strength. And don't run away from it. It is a choice about focusing on yourself and on your family first, because it's really, I've met some individuals where it's stage 1, they ignore it. Next thing you know, it's stage 4. And that's such a devastating development. Or a situation where they feel a lump, they don't address it, they don't take it seriously. And I believe, Dr. Tang, you don't just take care of breast cancer patients, you also take care of anything related to the breast. So even if it's the screening part, is this correct, Dr. Tang?
Absolutely.
Yeah.
Any kind of breast condition.
Yes, and the same with Shani. I know that it's not just in regards lymphatic drainage for breast cancer. I have sent you patients after liposuction as well, all kinds of surgery, even eye swelling. There is some role of lymphatic drainage and therapy, and we haven't even gone through and touched the complicated topic of cording. So it's really encouraging to me that everybody has stayed, and I'm very sure there are questions afterwards. But I want to thank both of you and the entire audience for taking the time to listen to us. So this is Breast Cancer Month. Today is the first day. Please take action. If you haven't done a mammogram yet, you're 40 years and over, please go to see Dr. Tang or a breast doctor or your gynecologist. With that, I want to thank everybody, and I'm going to sign off now. And I hope you enjoyed this. And it's wonderful and encouraging, and we'll plan other discussions such as these for the future. Thank you.
Thank you so much, everyone.
Thank you.
Thank you so much, Sylvia.
Thank you. Thank you.